Good morning, my student. I'm going to talk about diabetes in pregnancy. What is diabetes? It is a metabolic disease result from underproduction of insulin, which affect the carbohydrate, fat, and protein metabolism. We have two types of diabetes in pregnancy. Either the woman is pre-existing, she already have a diabetes type 1, type 2, or occur for the first time, and we call it gestational diabetes. What happened during pregnancy to the blood sugar and the insulin? The homeostasis during pregnancy. The fasting blood sugar usually maintained. There is no alteration of fasting blood sugar. The only thing that happened is there is insulin level, usually doubled. Why insulin level doubled? Because pregnancy is a state of insulin resistant. With advancing pregnancy, we started from the first trimester, second and third trimester, there is increased resistance to insulin because of two things. The first is the placental hormone. The placenta will secrete a hormone, which is the human placental lactogen, the estrogen and progesterone. All these hormones antagonize the effect of insulin. The second thing, there is changes in the peripheral insulin receptor. There's decrease in the insulin receptors فيشتغل كأنه there is no insulin in the body. There is further and further stimulation of insulin secretion from the pancreas. By which method the glucose will pass the placenta is by vacillated diffusion. I am going to concentrate it on gestational diabetes. What is gestational diabetes? It's diabetes. It is a state of glucose intolerance. When it occurs, usually in the second trimester, end of second trimester, and early third trimester, and met WHO criteria for diabetes. The most important thing is to revert to normal after puerperium. Incidence مالتها 1 per 1000 deliveries, 1 per 2000 deliveries. What is WHO criteria? ذكرناها بالتعريف. WHO criteria consider patient diabetic when the fasting blood glucose equal to or more than 8 millimole and 2 hour postprandial equal to or more than 11 millimole. يعني ورا ساعتين من الأكل لما يسوي blood sugar يطلع لنا 11 and or more millimole per liter. A normal person has a fasting blood glucose less than 8 and 2 hour postprandial less than 11 millimoles. How would we screen for diabetes? Is there any definitive screening test? No. There is no definitive screening test for diabetes. Can we consider glucose tolerance test a case of screening? No. It is a case of or a tool or a diagnostic tool used for diagnosis of not for screening, but we can use it for a high risk pregnancies. يعني واحدة عندها first degree relative، يعني أمها أبوها عندهم diabetes we subject patient for a glucose tolerance test. واحدة عندها poor obstetrical history previous abortion previous stillbirth نسوي له. واحدة عندها glycosuria عندها glucose in the urine on 2 occasions، فهاي نسوي لها جلوكوز توليرانس تيست. بعد ما نسوي هذول أهل البوليهيدرامنياس، هذول أهل الماكروسوميك بيبي. What is macrosomia? Macrosomia when the fetus or the baby's body weight is 4 kilogram and more. We consider infant is macrosomic. إذا obese women, إذا women more than 35 years of age, we subject them for glucose tolerance test. Is the glucose tolerance test subjective for a low risk pregnancy? No. دول كلهم بنسميهم high risk pregnancy. Low risk pregnancy, there is no need to do glucose tolerance test because it is costly. Second, it's invasive, it's time consuming, it is not considered as ideal method for screening for diabetes. Other method for screening for diabetes, we have glucose challenge test. We have glycosylated hemoglobin A1C, glycosylated protein, glycosuria. These are all methods but not ideal for screening for diabetes. كل الميديكال illnesses بنريد نحكي we have to يعني assess the effect of disease on pregnancy and effect of pregnancy on the disease. First, we are talking about the effect of diabetes on a pregnancy. What happens if a pregnant woman become diabetic? First, it may affect the fetus, it may affect the neonate, and it may affect the mother. In the fetus, it increases miscarriage, especially first trimester marriage, due to aneuploidy, due to congenital anomalies. فراح يزيد عندها الريسك يزيد عندها مالت البلاتد ovum. In the second trimester also it increases the risk of second trimester fetal death due to congenital anomalies. In the third trimester there is increase of stillbirth. Stillbirth due to metabolic changes. Metabolic changes due to difficulty with control of diabetes. There is hyper or hypoglycemia, and the second thing is hyperviscosity of blood. What other complication? There is increased risk of congenital anomalies. We have three types of congenital anomalies: skeletal, cardiovascular, and neural. عندنا يزيد النيورال تيوب ديفكت، يزيد عندهم الكاردياك abnormalities مثل tetralogy of Fallot or ventricular septal defect، ويزيد عندهم السكليتال مثل يصير عندهم كودر regression syndrome، يصير ذولا أهل الدايابيتس. بعد شنو عندهم الإفكت يزيد الإفكت مالتهم مال pregnancy induced hypertension، ويصير عندهم fetal macrosomia. Why في fetal macrosomia in diabetes? There because there is high blood sugar. This blood sugar, which is continuous during day and night, will pass to the placenta and then to the baby. And the baby to stimulate the insulin from the pancreas. What happened to the fetal pancreas? It will become hypertrophic, especially island cells of Langerhans. And this insulin, which is increases in excess amount, is a growth promoting. It's to promote the growth of the baby, and the end result is macrosomic baby. What have other complication? Also increase the risk of polyhydramnios, and consequence of polyhydramnios is the preterm labor. Neonatal effect is what is the neonatal effect? There is increased risk of hypoglycemia, as we mentioned. There is hyperinsulinemia and hypoglycemia. There is risk of polycythemia. A destruction of excess RBC in the fetal blood or neonatal blood will result in hyperbilirubinemia and RDS, birth asphyxia, macrosomia causes birth trauma, especially with vaginal delivery, and the risk of hypocalcemia and hypomagnesemia. What about maternal mortality? Maternal mortality usually decreased after insulin early يعني the discovery of insulin, but still there is effect may affect the kidney, affect the eye, and causes preeclampsia. Risk of infection also increase in the mother, especially the moniliasis urinary tract infection. Why monilia increase? Because there is excess glucose in the vagina. And this glucose in the vagina, by the effect of Doderland bacilli, will change into lactic acid. And this lactic acid will alter the pH of the vagina and causes acidic, which in favor the candida and infestation into the vagina. Also, there is hypoglycemia and decrease in the operative delivery. يعني 50% من ذول الأهل الدايابيتك may develop delivered by cesarean section. هسه نجي نحكي على الإفكت of pregnancy on diabetes. What is the effect of pregnancy on diabetes? أول شيء راح يسوي لنا difficulty بالcontrol. يعني there is hyperglycemia. بالearly pregnancy there is tendency for hypoglycemia. ليش صار عندهم hypoglycemia؟ لأنه because of nausea, vomiting, intolerance to food، فيصير عندهم control difficulties. هاي رقم واحد. ثانيا إنه there is decrease lowering renal threshold. There is excess secretion of glucose in the urine. And ثالث شيء إنه there is diminished sensitivity to insulin as a pregnancy. مثل ما قلنا placental hormone والreceptor size. Placental hormone increase causes difficulty in the control of diabetes. The second effect of pregnancy on diabetes يعني هاي وحدة pre-existing diabetes type 1 or type 2. وعندها مثلا nephropathy may worsen, retinopathy may worsen. حتى ذول أهل ال previous proliferative متحول more serious form اللي هو ال proliferative retinopathy اللي هو يكون contraindicated in pregnancy because it ends with blindness. How would we manage a patient with diabetes. It is we need a team of worker, diabetic someone diabetic team, which consists of physician, obstetrician, pediatrician, and dietitian. The second principle is strict metabolic control. We have to control diabetes before pregnancy, at the time of pregnancy, and after pregnancy. And we need to increase the frequency of antenatal visit. How would we achieve euglycemia? And either patient that discovered for the first time she is diabetic, يعني نسميها gestational diabetes, or she is already on oral hypoglycemic drug. We stop the oral hypoglycemic drug because it contraindicates during pregnancy, and we started with diet. We keep the patient on diet for 2 weeks. If it is uncontrolled, then next step is to use the insulin. الدايت هنا وأساس الكالوريز needed per day، نحسب لها 35 كيلو كالوري per day، ويعتمد على البادي ويت مالتها، ونضيف لها 300 كيلو كالوري to anticipated weight gain during pregnancy. يقسموها إنه تاخذ 50% كربوهيدرات، 20% بروتين، 25% يحطوا لها فات بالأكل. If there is no control for 2 weeks on the diet, we shifted to the insulin. How we would give the insulin؟ الانسولين مثل ما قلنا الاورال جلايسيميك نحولهم على انسولين، اذا هي ما على الانسولين بس على الدايت نحولها على الانسولين. It is preferable to use two types, short acting والintermediate acting. ننطيها in two divided doses. واحدة ننطيها الصبح وننطيها العصر. ننطيها ثلثين الجرعة تاخذها الصبحيات، وثلث الجرعة تاخذها بالليل. مثل تاخذ الساعة 8 الصبح تاخذها ب8 بالليل. مثل تاخذ 30 يونت انسولين فنحطيها 20 يونت الصبح و10 يونت بالليل. من هاي ال10 يونت بالليل نعطيها نص سوليبل ونص لنتي ننطيها، بينما دول أهل الصبح نعطيها ثلثين شو يسمونه اللنتي وثلث سوليبل نعطيهم وياه. شلون نحسب لهم الكالكوليشن؟ نحسب لهم على الجستيشنال ايج والبادي ويت. اذا كانت بالفرست ترايمستر نضرب البادي ويت في 0.6 نحسب لها انسولين، بالسكند ترايمستر 0.7، والثيرد ترايمستر نعطيهم 0.8 في البادي ويت، تطلع لنا ايش قد تحتاج لها انسولين بير داي. How would we schedule؟ مثل ما حكيت نعطيها ثلثين الصبح وثلث بالليل. من هاي مالت الصبح ثلثينهم انترميديت وثلث شورت اكتنج. وبنت الصبح بتاخذ 20 هنا الصبحيات، فننطيها تقريبا 14 نعطيها الصبح و6 شورت اكتنج، 14 انترميديت و6 شورت اكتنج. بالليل تاخذ 10 نعطيها 5 يونت سوليبل و5 يونت انترميديت. الايم مالتنا is to keep the pre-brandial blood sugar less than 60 millimole per deciliter، او نبقي على ال100 الفاستنج مالتها، فاستنج جوا ال100. الاكسرسايز there is no contraindication. We have to encourage exercise. تجينا المريضة diabetic أو هي gestational diabetes. how would you follow her up؟ أول شيء نسوي لها detail ultrasound. شو وقت نسوي لها الفيرست ultrasound at 16 to 20 weeks of gestation، الثاني بالثيرد trimester، يعني بالسكند trimester بالثيرد trimester. بالسكند trimester to confirm or exclude the congenital anomalies، بالثيرد trimester to assess fetal well-being and fetal growth، ونسوي لها البايوفيزيكال بروفايل. ايضا نسوي لها fetal echo، نسوي لها سيرم الفا فيتو بروتين to exclude or confirm the neural tube defect، ونسوي لها assessment للمother also، نفحص العين مالتها، نسوي لها ophthalmological examination، نسوي لها cardiac examination، نسوي لها renal examination، لها full investigation. وبالإضافة إلى glycosylated hemoglobin A1C نسوي لها كل شهر. شو وقت نجيبها للمرض؟ التايمينج اوف ديليفري تعتمد لنا على 3 things. اذا المرة ستيبل والفيتال جروث از جود وهي ايوغلايسيميك يعني بلاد جلوكوز مالتها از كنترول، فنجيبها term not beyond term. term نقصد به 38 to 40 weeks. if the condition is not met يعني there is difficulty with control, fetal growth is not satisfactory, maternal state is unstable, we have to intervene. if the patient develop labor in labor يعني سواء vaginal delivery or by cesarean section، خاصة بالvaginal delivery we have to keep the patient euglycemic. How would you keep it? We put 2 units of insulin in 10% glucose water and throughout the pregnancy, throughout delivery, the first stage of labor, we measure blood glucose كل ساعتين. If there is an increase بالبلاد glucose, we increase the numbers مالت الدروب in the شو يسمى مالت الانسولين. If there is decrease, we decrease the level of drops. The aim مالنا is to keep the blood sugar 100. ونسوي طبعا fetal monitoring والmaternal monitoring. والايم مالتنا احنا vaginal delivery، بس مثل ما قلنا there is increase in the risk of cesarean section by 50%. In the postpartum period, how would we deal with the patient postpartum period? We stop the insulin for 48 hours and we depend on the sliding scale. نحسب لها كل 50 ملغ increase بالبلاد شوجر above 150، يعني هو النورمال level نعتبره 150، كل 50 فوق ال 150 نعطيها 10 يونت soluble insulin، فنعتمد على الستاندنج سكيل. فطلعت هي 250، فايش قد فوق ال 150 عندنا 100 كل 50 نعطيها 10 يونت، فنعطيها 20 يونت لحد ما يروح الإفكت مالت البلاسنتال هرمونز. What about the contraception? The best method هي البارير method. Is there any contraindication for combined pills? No, but it's still risky. Progesterone cannot be used because its failure rate عالي والIUCD causes infection. The best method is barrier method for those diabetic. What about sterilization? Only if there is retinopathy or vascular involvement، يعني there is hypertension or cardiac abnormalities فنسوي لها sterilization.